We now proceed to Dr. Atul Goel's talk, and I've been given the damn difficult job of introducing Dr. Atul Goel, and not only introducing him, but I've been told to keep his talk brief. I don't know how I'm going to do it.
Brigadier Saab, you don't worry about keeping my talk brief, because I was never before. I have pre-recorded my talk, so it is pre-recorded and it will be as long as has been recorded. So don't worry.
Otherwise, it is said that Dr. Atul Goel and brief, it's an oxymoron.
So let's hear what I have to say. Okay.
Sir, please go ahead with your talk on the new concept in atlantoaxial dislocation.
Okay, it has been recorded. Can you instruct Shraddha to?
Saurabh?
So it is my great pleasure and an honor, and I thank Professor Ramani to invite me, Dr. Sahu to invite me for this forum, and it is an opportunity for me to give my thoughts on this entirely revolutionary concept of central or axial atlantoaxial instability. Atlantoaxial joint is the most mobile joint of the body. Occipito-atlantal joint is the most stable joint of the body. Atlantoaxial joint is most mobile and it is most susceptible to instability. It is most unstable joint of the body. You see, there is round joint. There are no rugged ligaments like on the upper surface of atlas facet. Circumferential movements and the circumferential possibility of abnormal movements. Mobile atlantoaxial dislocation, we all know, have been treating for more than 1 century. Atlantodental interval increases on flexion, reduces on extension, and stabilization and fixation is the treatment. This was another milestone in the treatment of craniovertebral junction anomalies and abnormalities. Fixed atlantoaxial instability. We described that there is nothing like fixed atlantoaxial instability. You open the joint, manipulate the facet, and reduce the dislocation. So this concept has completely changed the treatment of atlantoaxial fixed dislocation. So this is fixed on flexion and extension, does not change. The only described treatment was transoral removal and decompression, but there is a possibility of reduction and fixation without doing any kind of decompression. So this is another case. You see flexion and extension, transoral decompression was the treatment, but there is a possibility of craniovertebral junction realignment. So there is nothing like fixed dislocation. Atlantoaxial joint disruption following trauma, the only treatment possible in such situations was decompression. But of course, there is a possibility of opening the joint, realigning the craniovertebral junction, and doing stabilization in reduced position. Rotatory dislocation is another common kind of dislocation, particularly in this age group of children. The only treatment that was described was decompression. So we introduced the concept that you open the joint and reduce the dislocation, and you can certainly give new life to these rather unfortunate children. This is vertical dislocation. You see in extension, it is reduced. In flexion, it is dislocated. There is no neck. There is multiple joint fusions. And there is possibility of doing fixation in reduced position. Basilar invagination was considered worldwide by everybody in the world as fixed atlantoaxial dislocation. In 1998, I wrote this article where I said basilar invagination is of 2 types, odontoid going up and tonsil coming down. Transoral decompression was for this group 1 and foramen magnum was relevant for group 2. The concept was that it is fixed. The treatment was that it is to be decompressed. However, in 2004, we introduced the concept that group A is an unstable situation and you can do craniovertebral junction realignment and fixation. We still thought in 2004 that group B needs decompression because we thought it is a stable or fixed atlantoaxial instability. So this is basilar invagination reduced on dislocation. reduced by distraction, reduction, and fixation. So this introduced entirely a brand new concept in the field of craniovertebral junction. We related in 1998 basilar invagination to lumbosacral listhesis, like C1, C2 listhesis. So C1, C2 listhesis was considered to be the cause of basilar invagination. Like you treat listhesis, you treat C1, C2 listhesis. And that was our concept. And we treated many patients, and this concept was quite popular. And this paper is quite widely cited. So there is basilar invagination, as you see. And if you carefully see, there is listhesis of C1 over C2, and the treatment is realignment, and there is no need for decompression. In the year 2008, we introduced this concept of central or axial atlantoaxial instability. If you read between the lines, you will see that such instability is not only in basilar invagination, but in Chiari malformation, syringomyelia, myelopathy related to cervical degeneration, spinal deformities, OPLL, Hirayama disease, and several other known pathologies where we actually treat them differently. So now this is the new classification of mine. Type 1 is when the facet of C1 is dislocated anterior to the facet of C2. Atlantodental interval is increased, there is cord compression, there is listhesis, and the treatment is stabilization. Now you carefully see this slide. There is no atlantodental interval disturbance, there is no cord compression, there is facetal listhesis, type 2. The facet of C1 goes behind the facet of C2. So this is an unstable situation. So we said that these patients do not need decompression, they need stabilization. So as we mature further in the business of craniovertebral junction, we identify that there are several telltale clinical and radiological evidences like Chiari, like syrinx, and several other known features which are considered in general to be pathogenetic by themselves are indicators of unstable atlantoaxial joint, like assimilation of atlas in this situation is an indicator. Chiari, syrinx are indicators of unstable joint and unstable atlantoaxial joint meriting the need for stabilization. And you see the syrinx has reduced without any question. Several people, particularly in China, are referring to this kind of treatment for Chiari. So this dislocation of facet of atlas behind the facet of axis is another concept. So there is no atlantodental interval disturbance. There is no neural or dural compression. This is an unstable situation. So this kind of basilar invagination, which is treated worldwide by decompression, you see there is a type 2 atlantoaxial instability, and these patients need stabilization without any doubt, and don't keep any confusion. So this is another case, basilar invagination. There is no atlantodental interval disturbance, syringomyelia, facetal type 2 instability, and stabilization. Difficult operation, no question, difficult, but no question, fantastic and beautiful. So Chiari malformation is an indicator of an unstable atlantoaxial joint, even when there is no atlantodental interval disturbance, even when there is no facetal malalignment. You do atlantoaxial fixation and you see an absolute magic. You see a magic which you have not imagined. So basilar invagination is always associated, both type A and B are associated with an unstable atlantoaxial joint, and we have introduced several hundred patients where we have said both groups need only one treatment, and they are the children of same father. That father is atlantoaxial instability. So atlantoaxial instability has several children. These are basilar invagination, syringomyelia, Chiari formation. The atlantoaxial is a motivator or an initiator of all these problems. And if you solve this stability issue, everything else can be treated by itself. So Chiari malformation, we introduced this article about 10 years ago, where we said that atlantoaxial instability is the cause of Chiari and atlantoaxial fixation is the treatment. And we have now published several articles on this subject. Even when there is no basilar invagination or there is no bone abnormality, Chiari and syrinx are indicators of an unstable atlantoaxial joint. And recently we have introduced our article with experience of 400 cases of Chiari and syrinx with magical clinical outcome. You see no atlantodental interval disturbance, no facetal malalignment or minimal malalignment, see syringomalia, do atlantoaxial fixation, not an easy procedure in presence of syrinx and presence of Chiari malformation, and you see the magical outcome on syrinx. More than radiological outcome, the clinical outcome is as good as you are giving new life to the patient. So, and syrinx will disappear in 100% of cases wherever the scan is done after 1 year at least. And you can have at least 20% of patients syrinx reduced if you do a scan within 15 days of surgery. So tonsillar herniation, no atlantodental interval disturbance, no facetal malalignment, treatment is atlantoaxial stabilization. So this is syrinx, see the instabilities and see there is no atlantodental interval disturbance, and you see the syrinx reduced after, this is immediate post-operative period reduced, and patient outcome is absolutely thrilling to say the least, and you give a brand new life to the patient. So this is another case, and there is unstable joint type 2 and syrinx has reduced. So I have got several 100 patients, as I have mentioned. Recently, I wrote an article with my experience with 400 cases. Idiopathic syrinx sometimes is also another child of atlantoaxial instability. You treat atlantoaxial stabilization, otherwise you do shunts and all those kinds of treatment, which may not just be necessary, and you give new life and a new radiology to the patient. Kyphoscoliosis in presence or even without presence of Chiari. Remember my statement, with or without presence of Chiari, this kind of kyphoscoliosis in young children is almost always a result of central atlantoaxial instability. You do stabilization without doing any instrumentation on spine. In the immediate postoperative period, you can have a straight and beautiful neck and spine. So central and atlantoaxial instability can be a big cause of cervical myelopathy. There are telltale evidences, like in this case, there is bifid. You can have Klippel file, you can have basilar invagination, you can have platybasia. Those are all telltale evidences of one problem. Even when there is no compression at the craniovertebral junction, if you want to give this new smile to the patient, and if you want to have your own beautiful smile, you do atlantoaxial stabilization. Degeneration of craniovertebral junction, no, not much has been discussed in the literature, but it is quite a common clinical entity. So we said that osteophytes, reduction in joint space, posterior buckling are all secondary to vertical spinal instability. Whenever we talk of degeneration spine, we talk of C3, C4, C5, C6. We never talk of atlantoaxial joint, but I have to tell you that atlantoaxial instability is the most common form of spinal degeneration, and in OPLL and in cervical spondylosis is quite frequently present. So subaxial and atlantoaxial instability is a huge cause of multi-level cervical spondylotic myelopathy. I will suggest you please read my articles on this subject. This kind of patient, no compression at the craniovertebral junction, but you see the facetal instability, you have to include C1, C2 into the stabilization construct, and beautiful clinical outcome is guaranteed for you. You see there is compression, don't remove this disc. You do stabilization, but do not forget C1, C2, and you see the magic clinical outcome, particularly when the patient presents with severe myelopathy. Craniovertebral junction instability is uniformly present even when there is no compression at the craniovertebral junction. So OPLL very frequently is associated with multi-level joint instability and atlantoaxial instability. Only stabilization is a magical form of treatment. You see, this is OPLL, and there is no atlantodental interval disturbance, no C1, C2, problem, but I have done C1, C2 fixation, and I can only tell you a magic has been created. So this is another case. You see, this C2-3 fusion is as good as a modified form of atlantoaxial fixation. I will suggest please read my article on this screw. So these patients do not need decompression, they need stabilization. So atlantoaxial instability is a very common association with OPLL. Please do not forget it. So ossification of, so this is another article of mine published in Acta Neurochirurgica, and you see I have included C1, C2 in the fixation construct. And now I have got several patients with this kind of treatment. So atlantoaxial instability or central atlantoaxial instability is a, if you understand this concept, you can revolutionize the treatment of OPLL and of degenerative spine. And similarly, Hirayama disease, if you realize that there is central instability, you can change the treatment format that is currently available for you. So that's it, my dear friend. Thank you very much. I hope you have liked it. I hope you have enjoyed it. And I hope Dr. Ramani will give me good marks in my presentation. Thank you very much.
Thank you, sir. And as usual, whenever we listen to your talk on atlantoaxial dislocations or craniovertebral junction, we do come out wiser. Thank you very much. And
thank you. Thank you. What about my talks on other subjects? You come out wiser only in craniovertebral junction.
Okay. Let me moderate one of those talks and I'll take it.
Okay, Brigadier Saab, okay.
So we move on to the is there any anyone from the audience or from the faculty who would like to or who would dare to ask a question? Thank you, sir. Thank you very much.
Thank you very much.